This video explains a Crestal sinus elevation protocol for delayed implant placement. Crestal sinus elevation with immediate implant placement is not recommended when crestal bone levels are less than 5 millimeters thick. However, crestal sinus elevation with delayed implant placement is an effective, reasonable alternative. Why is delayed implant placement effective? Because crestal sinus elevation with delayed implant placement increases the vertical bone height in the sinus prior to implant placement. When the implant can be placed 1 to 2 millimeters below the alveolar crest, it reduces the concern for implant stabilization, marginal thread exposure, gingival inflammation, future crestal bone loss, and the potential for the development of periimplantitis. Requirements for sinus elevation with less than 4 to 5 millimeters crestal bone. The surgery should be completed 6 weeks to 3 months prior to implant placement. After 6 weeks or more, post-grafting, with the aid of a biologic, the implant can be placed in the previously grafted site. If a biologic is not used with the graft, a longer healing period of 10 to 12 weeks may be necessary. Use of biologics increases the rate of graft mineralization and shortens the time for osseointegration. A surgical guide is necessary for sinus elevations without flap reflection. Lab-fabricated or printed surgical guides can be utilized to center the osteotomy buccolingually below the center of the sinus cavity for sinus elevation with delayed implant placement. Later, the same guide can be used to place the implant in the grafted site. Shorter drills are needed to start the osteotomy without perforating the sinus membrane. Extra short 1.5 to 2.2 millimeters tapered drills with lengths of 2 and 3 millimeters are available to start a case with only 2 or 3 millimeters of crestal bone height.
Let me remind you that the Crestal sinus elevation drills have a reverse twist, and when they are rotated according to the diagram on the container top, they are pushing bone in front of them, and the bone particles lift the sinus membrane upward. If they are used incorrectly with the wrong rotation, they will perforate the sinus membrane. The two probes of different diameters and the Valsalva maneuver are used to confirm the ongoing status of the sinus membrane during the procedure. The drills increase in 1 millimeter intervals for a specific reason and should always follow sequentially.
Here, the 4 drills for cases with minimal crestal bone can be seen. 1.5 millimeters to 2.2 millimeters tapered, and 2.0 tapered to 2.9 millimeters tapered drills 2 and 3 millimeters in length.
If the 2 and 3 millimeter length drills do not penetrate the shallow crestal bone, continue on with the 3 and 4 millimeter length drills and longer drills until they lift the crestal bone and the sinus membrane. Then use the depth-stopped plugger instrument to add additional collagen or particulate graft material to elevate the sinus membrane farther.
The sinus models have several thickness of the sidewalls, allowing practice on the thin and thick floor of the sinuses. All Crestal sinus kits are shipped with samples of the Sawbone practice models. The 4 extra short 2 and 3 millimeter drills can be seen here in the new cold block. When using the cold block, it is best to use the stainless steel drill keeper to prevent the drills from falling out if it is accidentally tipped upside down. When the sinus elevation drills are reduced to freezer temperature prior to the start of the surgery, the drills do not need external irrigation and maintain the cold temperature for at least 30 minutes. Why is this useful? It reduces the risk of contamination of the collagen plugs or other graft material being placed in the sinus elevation protocol. The guide write 4.4 millimeter and 5 millimeter depth-stop Crestal sinus elevation drill set can also be used for sinuses with minimal crestal bone. First, extra short 2 and 3 millimeter drills are used to initiate the osteotomy and raise the sinus membrane. Then the standard protocol is followed. 2-degree taper drills increasing in 1 millimeter increments. The drill lengths range from 4 millimeters to 10 millimeters, diameter range 1.5 millimeter to 4.7 millimeters. The initial sinus elevation drills are used to elevate the Schneiderian membrane by removing autogenous bone from the patient's alveolar crest and pushing it forward to lift the sinus membrane. Additional bone grafting materials, osteogen and biologics, are used along with the patient's bone to elevate the sinus membrane to provide more space to accommodate an implant of sufficient diameter and length to support the planned restoration. Larger implants require larger grafts, and larger sinuses also require more graft material. These are the components of the 4.5 and 5.0 millimeter depth stop Crestal sinus elevation drill sets.
The rose-colored stainless steel storage containers measure 3 5/8 inch by 4 1/4 inch by 2 3/4 inch. They are PVD coated with silicone inserts and are used to store and clean the drills. The drills have their millimeter size indication, laser inscribed for easy recognition after autoclaving. The drill box also can be placed in a freezer for 1 hour prior to use for the cold drilling protocol. The metal drill box maintains the cold temperature of the drills when removed from the freezer for 20 minutes. This minimizes the heat generation and reduces the risk of damage to the bone and results in less discomfort for the patient. Drilling without irrigation reduces the risk of contamination of the osteotomy when pushing bone and collagen up to elevate the sinus membrane. Solid 1/2 inch thick aluminum and stainless steel blocks are also available to maintain the cold temperature of the drills for 35 minutes, a longer period of time. The initial extra short 2 and 3 millimeter long drills for cases with minimal bone height are not included in the basic set, but are available on request through our website www.deplaque.com. The new additional 2 and 3 millimeter depth stop drills are used when the crestal bone is very thin. If there is less than 3 or 4 millimeters of crestal bone, the implant placement must be delayed for a minimum of 6 weeks for the graft to heal.
Two 15 millimeter probes are used to detect the presence and continuity of the sinus membrane. The smaller periodontal probe is 0.7 millimeters diameter at the tip. The larger sinus probe is 1.5 millimeters diameter at the tip.
Probe the site after use of each of the gold drills, increasing in length at 1 millimeter intervals. When the probing feels soft with the small probe, it indicates you are probing against the membrane. When you probe this site with the larger probe tip, it should still feel hard because the larger tip is not probing through the bone or reaching the membrane. After using the next larger rose-colored drill of the same length to increase the diameter of the opening, the larger probe tip will now probe through the bone to the softer membrane through the larger opening in the bone. The remaining drills used can increase in diameter but not in length. At this point, the status of the membrane should be checked with the Valsalva maneuver. The adjustable depth stop plugger is used to push up soft collagen material to elevate the sinus membrane. The concave tips are present at either end of the handle. Markings are at 2 millimeter intervals on the larger 4 millimeter end of the plugger. The adjustable depth stop is located on the small 3 millimeter end of the plugger. The depth stop should be set according to the length of the longest drill used to elevate the membrane. The small end can be used after the rose-colored drill is used. The original drill sequence is started with the gold drill series, 1.5 to 2.2 millimeters diameter 2 degrees taper drills, using them up to the depth that the sinus membrane can be probed with a probe that is the same or smaller diameter as the drill tip. The drills increase in length by 1 millimeter intervals, starting with 4 millimeters and increasing to 5, 6, and 7 millimeters up to 10 millimeters, when the osteotomy provides an opening of the bone below the membrane. Next, larger diameter drills of the same length are used. Each increasing diameter drill pushes additional bone particles removed from the wall of the osteotomy up to lift the sinus membrane. The final drill diameters used are dependent on the diameter of the implant plan to be placed at the site and the width of the sinus cavity. The new starting drills are the same diameter but shorter, 2 and 3 millimeters in length. Step 1. Use a gold 1.5 to 2.2 millimeters drill to depth of 1, 2, or 3 millimeters. Checking for perforation of sinus floor at each depth with the narrow periodontal probe. Step 2. Then increase the drill depth by 1 millimeter. Check again for perforation with the narrow periodontal probe. When the probing feels soft, you are most likely at the level of the membrane. Step 3. Next, use the thicker 1.5 mm sinus probe. If it feels hard again, you are most likely at the level of the sinus membrane because the larger probe does not penetrate the bone. Step 4. Now that you have determined the level of the membrane, increase the diameter of the drill to the rose-colored drill series with a 2.0 mm tip diameter of the same length. Step 5. Check again with the larger diameter 1.5 mm sinus probe. If it now feels soft, you are definitely at the level of the sinus. Use the next larger blue drill series of the same length to open the width of the osteotomy. Do not increase the length of the drill.
Step 6. Use the silver drill 3 to 3.9 mm of the same length to enlarge the diameter of the opening in the sinus floor to 3.2 mm, so you can use the 3 mm plugger to push collagen graft up to elevate the membrane. Step 7. Use the black 6 mm drill to depth if a 5 mm implant is planned. Step 8. With the adjustable concave plugger, additional collagen material is pushed under the sinus membrane. Step 9. Implant placement is delayed at least 6 weeks if a biological agent BMP2 is used in the sinus elevation. If a 4 mm diameter implant is planned for the site, the drilling protocol should be stopped after the silver 3 to 3.9 mm drill is used. The black 3.7 to 4.7 mm drill should only be used for implants 5 mm or greater in diameter. The 3 mm plugger can be used after the rose-colored 2.9 mm drill is used. The 4 mm diameter plugger tip can only be used after the black 3.7 to 4.7 mm drill is used. After the graft height is determined by an X-ray and the graft is of sufficient height for the planned implant length, the site is closed or partially closed with sutures. If the biologic infuse was used, the graft site should be allowed to heal for a minimum of 6 weeks before placing the implant. If no biologic was used, wait 12 weeks or longer and take an X-ray to determine the degree of mineralization before placing an implant in the site.
Recommended grafting materials. Always start the elevation with softer collagen materials to lift the membrane. Infuse requires a carrier, and collagen acts as the carrier. Infuse will not bind to mineralized bone. Minerus is made by Medtronics, has an abundance of collagen, as does Poros and osteogen, as seen in the SEM photo micrographs shown. The collagen will become more radio-opaque as it becomes mineralized. Mineralized bone can also be added to the elevation to make the graft more radio-opaque. If infuse, BMP2 is going to be used. It must be dissolved in sterile water or saline and added to the collagen carrier 15 minutes prior to placement to allow time for the protein to bind to the collagen sponge. Infuse will speed up the rate of mineralization of the graft. Infuse is a very concentrated protein, which occasionally results in minor swelling. Do not add excess liquid, as the protein may be lost when it is compressed when it is being placed during the sinus elevation procedures. I suggest using a 1/2 cc syringe to add 0.3 to 0.5 milliliters of sterile water to 50 to 75 micrograms of infuse. Preparation of 1 or more osteogen plugs, OPL 10 mm by 20 mm size. The collagen plug is sectioned lengthwise into quarters. Add at least 50 micrograms or more of the BMP2 or infuse, which is sold by Medtronic. Add 0.3 to 0.5 milliliters sterile water or saline to hydrate the infuse 15 minutes prior to insertion of the pieces into the osteotomy. Adding the liquid softens the material. Cut each 1/4 piece to smaller pieces, and use a collage pliers for the insertion of the pieces into the osteotomy. Then elevate the sinus membrane with the concave tip depth stop plugger. If the pieces are too wet, blot them with a dry sterile 2x2 gauze to remove excess water. The infuse will remain bound to the collagen after the liquid is removed. The infuse must be used within 2 hours of hydration.
Let's look at a couple of Crestal sinus elevation cases. A cast was made of the patient's maxillary arch. Holes were drilled at the planned implant sites. A diagnostic guide was made using the straight guide posts and 3 mm guide sleeves. A CT was taken and site number 3 was evaluated and indicated a 15-degree correction was made to the angle of the guidepost. Upper removable parts were placed on the guideposts to fit the 4.5 mm guide sleeves. The cast was lubricated and Primatech splint was applied to the cleats on the guide sleeves and the palatal surfaces of the teeth to form the final surgical guide. This is a case where it was decided not to place an implant at the time of the elevation because of the thin crestal bone. A crestal elevation was completed and the implant was not placed. The lower CT images were taken after the initial osteogen plug was sectioned and placed to elevate the sinus. Additional graft material and BMP2 was added after the CT was taken to raise the graft and the sinus membrane higher. 6 months after the graft was placed, the Hounsfield reading was 480. A 5 by 10 mm implant was placed in the grafted number 3 site. Another case with limited quality and quantity type 4 bone with bilateral sinus sites is evaluated for immediate implant placement. 5 implants were planned using a printed surgical guide with 4.5 mm guide sleeves. The fit of the guide was checked on the patient's cast prior to surgery. The surgery was guided, but the anterior site was flapped, and additional ridge augmentation was also completed on the facial surface of number 7 with titanium mesh, osteogen block, and 50 micrograms of infuse. The temporary prosthesis was replaced with the patient through the 4-month period of osseointegration.
This is the cross-sectional view of the 2 distal implant sites requiring sinus elevation. There is a very thin cortex with type 4 bone observed. Delayed placement was recommended.
Bone density. The circled sites were measured in Hounsfield units. Number 3 is -22, and site number 19 is 58.
This is the 3-dimensional evaluation of the maxillary right first molar site, the number 3 site. The bone is type 4, and the placement of the 4.1 by 10 mm implant will be delayed.
Evaluation of the number 14 site indicates type 3 to 4 bone at this site, a little better than the number 3 site, so the plan was made to place the implant at the time of the sinus elevation. The mean Hounsfield score was 58. The post-surgical panoramic view displays the result of the Crestal sinus elevation and immediate placement of the implant in the number 14 site. The site had D5 bone and inadequate or minimal mineralization. The site was grafted, and the implant was placed with difficulty and resulted in a mesial inclination. Although it is still restorable, delayed placement would have been a better choice. The bone density of the graft at the number 3 site was measured at 231 Hounsfield units using in vivo 6 software. After 6 weeks, healing additional osteogen with BMP2 was placed at the number 3 site, then a 4.1 by 10 mm tapered implant was placed, and the periapical radiograph was taken. In summary, the Crestal sinus elevation protocol with immediate or with delayed implant placement should be considered and evaluated for each site with less than 5 mm of crestal bone height below the sinus membrane or with type 4 or 5 bone density. This is an alternative approach to a lateral window sinus elevation.
Thanks for watching. For more information, check the manuals on our website or view our other videos on Crestal sinus elevation, practicing with the Sawbone models, or fabrication of surgical guides on YouTube at GuideRight Protocol.